Margaret Forresky, and I'm responsible for the Technology Enabled Care programme over the last number of years, but obviously we've been doing quite a lot of focused work in the context of COVID and mobilisation and recovery going forward. So this is really an opportunity to bring you up to date on some work we've been progressing, specifically around remote monitoring and COVID, both in the context of COVID patients, but also for a wider application as well. John Conahan had issued out letters to boards, obviously about mobilisation plans, and then Caroline Blair wrote out to boards the remote monitoring. So thank you for joining the call today, and we will be doing some follow-up individually with boards, but there'll be plenty of time for questions and discussion. So I'm joined by a number of colleagues. I've got Morag Harty and Scott Henderson, who are working with me on the National Remote Monitoring Programme. We've also got Joe and Tom from the tech project team, who've been doing beavering away with all the preparation and support work. And I think we may be joined by some colleagues from the Modernising Patients Pathways programme as well. So we are looking at how we coordinate the work on remote monitoring and asynchronous appointments going forward. By way of sort of just points for the session is being recorded, so please let us know if you don't want to be included. If you can, keep on mute unless you're speaking, just to avoid any background noises. And it depends on bandwidth and things, but sometimes turning off the video gives greater clarity and doesn't drop off. Please do use the chat function to ask questions or make comment. We will be reviewing those and pulling people in, obviously, and the hand function, if you can use that if you want to ask a question as well, so that we can see you. We will also make available the slides to you afterwards, and do let us know if the audio fades off or you can't hear it particularly well, or if some of the slides aren't very clear, but hopefully the technology will work. Okay, next slide, Morag. So really for today's session, it will be bringing you up to speed on the national response to COVID in the context of the work we've been doing on remote monitoring. It'll also just contextualise that with some of the background work we've been doing for the last few years. It'll set out some proposals for a structure and a programme going forward. We'll also talk about the remote health monitoring platform that we've just procured, timescales and next steps. And as I said, plenty of questions, plenty of time for questions. Next slide. So as I mentioned at the beginning, a letter went out to chief executives a couple of weeks ago, really just alerting to the work we've been progressing on remote monitoring with partners and colleagues. This will sort of set out a range of work that's underway. It'll make specific reference to in healthcare, which is the digital product we have just recently procured, and talk really about the range of work and how we build on some of the work underway, but specifically focus on some of the support required. Next slide. Morag.
So just to give you some background, because we're aware that not everyone is maybe aware of the work that's been going on in the remote monitoring field within the tech programme. So my name is Morag Harty, I'm the lead for that now. Previously, we've had a number of tests of change and some scaling up of the home and mobile health monitoring, such a catchy title there. And these are the results that came through. The majority of those were used using a simple Florence SMS texting system, and it covered a variety of mainly long-term conditions, but certainly included mental health and some health and well-being as well. From that, we were able to have a proper evaluation and some very positive feedback and economic evaluation at that point. And that led us on to being fortunate in being able to procure funding from the government to have a national scale up of the blood pressure programme, as that was seen to be an emerging need in primary care particularly, but certainly the evidence was beginning to emerge that showed some real benefits, not only to time and cost and travel saving, but certainly on the condition and actually the management and long-term management to optimum levels of blood pressure and the impact that could have on further complications. So over £1.2 million was allocated for the 2-year programme. We have 11 local partners from boards across Scotland involved. We were able to develop national Once for Scotland clinically advised guidelines and protocols that we put onto that simple text messaging system. We've been able to work with NSS and provide a document report which can be put forward into the document in the GP practices. And we put together the first iteration of a guidance pack aimed at both new areas using something like remote monitoring for the first time, and the more experienced board areas who had been part of the initial projects actually contributing, as we have always done, to the network of guidance and information, experience, and some good practice and some good documentation to share. I have to say at this point, we have got a really, and we have had for a number of years now, a really strong network, very much based on collaboration, networking, sharing the lessons, both good and bad, across the country. And that I thank everyone that's been contributing to that. We really have had some great times and very positive progress made there. The community pathway, when we came to COVID, it was quite clear there was a projected pathway there of care, right from the call coming into a general practice at the left-hand side there, thinking someone had COVID symptoms, right through the NHS 24, the 111, NHS Inforum, the live call handling hubs, the local assessment centres, through other services who were having to respond to COVID and COVID-related symptoms, to the hospital and hospital at home, and then back into self-care at home. We recognised there were 3 pinch points there, where we thought that digital and some remote monitoring could assist, if in particular if this expected second wave or the pandemic really escalated beyond the resources that were available in the local areas, and this is something that we could maybe help sustain that service delivery. So self-care at home, those were patients who were seen at assessment centres who had COVID symptoms but were not deemed unwell enough to require a hospital admission at that stage. However, there was a requirement for some sort of ongoing monitoring for a few days, a couple of weeks, just making sure that they didn't regress, they didn't deteriorate, and we were very aware of a sudden deterioration was a factor that could happen. So that was one area where we felt we could be helping that, because a daily phone call was perhaps not sustainable for larger numbers or indeed longer term. The other part to that was where we were seeing respiratory and other disease processes being sent home, patients with diseases who are at risk of COVID or COVID symptoms, who could be benefiting from some more intense monitoring just in the short term, or to at least keep them safe at home and prevent admission. And we did some testing there with a respiratory pathway. And at the other end there was the patients who were being discharged from hospital as quickly as they could possibly safely be. However, maybe some remote monitoring could support them in that shorter term at home, and particularly in the recovery periods. So that's where we felt we could benefit with some new, or certainly testing out some existing technology. The remote monitoring and asynchronous consultation support areas. These are areas that we've identified from our partners, from clinical experts and technical teams that have been able to say these are the things that are emerging, and I would say they're emerging, they're constantly being updated. The expected rise in the number of COVID patients did not happily happen at the stage. And that seems to be flattening out in most areas at the moment. However, the COVID-19 patients already had said their local hub, hospital discharges, care at home. Clearly, care home residents are currently and have been a key area for some clinical support to be put in there, and perhaps some digital monitoring could help. Elective and outpatients, they're beginning to be standing up again, back to their routine services, or as near as can be stood back up, usually with some elements of redesign into them. And these were services which were suspended for the last few weeks. So a number of areas there, long-term conditions and some different maternity care in particular has just started using some digital monitoring as well. Primary care, the long-term condition management there, chronic conditions, standing those services back up, and integrations with the different platforms, absolutely key to all of this, and linking back into that digital data, track systems, Sky stores. These are all areas of looking at. This is not an exhaustive list, I have to say, and it's not only about the one supplier. There's a number of different suppliers that we will help try and steer suppliers, providers into what's maybe the best option for their service. However, that's a starter for 10 for us. Hand over to Scott now.
Thank you, Morag, and good afternoon, everyone. So I'm just going to refer quickly back to Margaret's comments about Caroline Lamb's letter. That came out on the 21st of May. It set out an offer of support to health boards and health and social care partnerships, and it's to help inform the development of next phase mobilisation plans. Now, it's also there to help with this continued use of digital technology, and the idea is to be able to enable more people to receive their care at home. That offer of support comes at a time when there are existing national and local digital programmes all in progress. There's a really busy innovation landscape through SBRI, CivTech, DHI's activities, and there's Innovate UK activity as well. And on top of all of that, we have dozens of suppliers all offering to help with some really tantalising offers of free support and low-cost introductory offers. And this is all coming at a time where we now have this huge interest in remote monitoring and other asynchronous services. And it's recognised that things can get very complex and really quickly. Now, we already know that complexity is the enemy of change, and we really can't afford to allow things to get too complicated, or we're not going to be able to make the types of changes to services that we're desperately needing to do. So our approach to trying to simplify things has been to go out to the market and to source one new solution that could do lots of the things that we want from a single platform, rather than have lots of new platforms, each only doing a few of the things that we want. And in this way, we don't really add to the noise that's already there. So we arrived at the in-healthcare platform with the excellent support from colleagues of DHI. Now, building on our pre-existing work to procure a national remote health monitoring system, we were able very quickly to select a range of high-level requirements, and DHI then put a dozen or so suppliers through their paces. It was a two-step process, a two-stage process, involved a desktop exercise followed by shortlisting and then invitation to present. And the results, as you can see on the screen here, are pretty plain to see. And we're now delighted to be working within healthcare. Here's a quick look at the patient view. The red bar along the top there tells us that this is in the sandbox, so we're not seeing any live patient information here. And you can see that it's app-based. The system itself has a lot of very attractive features. First of all, it's multi-channel, so although I just showed you the app version, it's also web-based. We still have access to SMS services, which is really important for helping with digital inclusion. It does integrate with devices and sensors if we want it to. There's a list of things that it already connects with, and that can be enhanced and expanded. There's a pathway engine which helps control all the services, and as a toolkit that allows us to take existing services and adapt them for our own use in Scotland, and that can be done very locally. We can also build our own pathways if we wish to do so. In terms of integration, the system has open APIs, open standards, which means that it can quite readily integrate with our existing systems. Morag and I have had an opportunity to have a look at some of the reporting that comes out of the system, and it's really useful, really clear, really helpful. And the final box there is on third-party and data services. This means that we can link up to systems and use them in a way that helps with, for example, using Chi lookup so that we can get demographic data in, which helps make the onboarding of patients that much simpler. So one of the really important features of the in-healthcare offering is that they have a library of around about 100 different services that have already been developed by NHS clinicians and professional carers. And there have been contributions to that library from services in the NHS in Scotland as well. Now, this gives us a head start on at least some of the services that we anticipate that we will want to deploy over the coming months. This slide here is just a bit of a teaser. It's just to show that there are big lists here. There's about 3 or 4 pages of these lists, and you'll be able to have a look at this in a bit more detail later on. But these are the services that are included in the digital marketplace. Now, we've given this sort of brief overview of the in-health offering to a few different groups now. And at this point, we always have a few questions. So I'll hand you over to Morag, who will share with you the common questions that we've received and what our response is to those.
Thanks, Scott. Margaret, please feel free to come in because you did this yesterday. Thank you. So in terms of resources, people usually ask, what are the resources available for this? And we will provide some help around that. So the resources as far as staffing and support, we're not asking for budget procurement applications on this one. The actual funding for the platform has been provided. It was approved and it's been bought on behalf of Scottish Government. So that platform and its use, including the SMS and the platforms, and a great deal of it is all in the bundle, as it were, that has been provided nationally. As far as resources, we do have a small team in the tech programme, and we will be looking to hook people up with some additional support where that's required. But we are looking for the tech programmes in the local board areas to be, we're expecting that to be the mainstay of this. However, we'll bring together some expert users and provide training. And we have been very fortunate in having the opportunity for some partners who have already had the experience with this particular system to provide us with some support, either locally or nationally at that point. So we are trying to make something that's going to be bring together the right people at the right time, as it were. Information governance, again, we've had those 3 board areas already procured this system, so we're not intending having a national information governance pack. However, we will be able to share that information when people have our boards go to their own information governance for their DPIA locally and their local requirements. The integration aspect that Scott spoke about earlier, there is the background to that. It's an open API, and we do know that we can integrate it with solutions, but again, that will be a combination of local and national progress there. And to sign up, we'll take you through the process that we're proposing, where we're putting on the table what our offer is and what the ask would be of boards who are wishing to participate. But this is not something that we're asking for formal funding applications or anything like that. This is to support your own mobilisation plans, your own recovery plans that have been submitted to Scottish Government. Margaret, would you like to say any more on this one? You're much better.
No, I don't think so, Morag. I think you've covered. I mean, there may be some questions or that people want, either further information on. So I think, happy, for people to cover some of that in the chat, and we'll have time to pick up on those in terms of just practical aspects.
Absolutely. Thank you. I'll hand you back to Scott again then.
Okay, thank you, Morag. So I've described that we've got a complex environment and that we're adding a flexible platform to help simplify things. So how might that help us get to recovery? So what we found in the tech programme is the process that I'm showing you on screen just now is an approach that works really well if we want to develop and implement services quickly. The process starts with an idea about how we might be able to do things better, how we might be able to deliver a service better. And then it works through the sort of technical aspects of how technology could help make that happen, and then allows people to go out and try it out and work out the flaws and the kinks before scaling things up. As an approach, it helps us to understand the landscape and what we need to do to get things from the opportunity side of the table over to the spread and scale side. Now, it should mention here, and as I mentioned earlier, there are lots and lots of good things already in train and that they're already being implemented. And the idea is that although we've secured this platform called In Healthcare, it's not really there to replace the good work that's already being done. It's there to complement it. Those with good eyesight will see that there's quite a lot of opportunities on that left-hand side of the board, and that's really only scratching the surface. So we've got a very big task to get as many of those opportunities off that left-hand side of the board and all the way across to the right-hand side. So this is where we're going to want to have a bit of a conversation, and quite quickly. What we need to do is we need to be able to achieve all that right balance between what's national and what are local priorities, and we're going to have to pool resources to be able to make sure that we all get to where we need to be in the next couple of months. Our suggested approach to that is that we'll work through a number of phases. We'll do that at pace, but we want to avoid the duplication of effort, and we really want to end up in a place where we arrive at the place we need to be faster if we go together than really if we all went on our own. Just leave that up for a second so that people can read. So a phased approach like this needs coordination, and our proposed structure here is reflecting the current governance arrangements in government. We're proposing a coordination hub with Morag and team, and for that to be helping to coordinate across a number of work streams. The workstream approach allows us to leverage the existing strengths and expert knowledge that we already have, for example, in the Modernising Patient Pathway programme and with primary care colleagues. Our hope is that boards will be able to mirror this approach with their own response, and that they will pick the work streams that make the most sense to their local situation. In proposing to work together, it would be remiss of me to neglect to offer up some key principles. I'm not going to go through these one by one, but what I would say is that simplicity is really our friend here, and that when we're considering what we want to do in terms of services, we should be asking ourselves, what's the simplest thing that we can do to make a difference now? Let's make it happen now, and then work on how do we improve it, how do we embellish it, how do we make it better over time. It's that principle of the minimum viable product and then improve, improve, improve. The other one principle I'm going to call out here is the one on collaboration. And I think that we really can make the best use of our collective resources if we put our mind to that. And I think it's really important because we are all in a hurry, and there's a real danger here that we can all go off doing 101 things and only achieving 10% of what we really could have. So there's quite a lot of opportunity for us to work quite closely together. You'll see and maybe recognise the service development process mapped along the top of that table there. And I've mapped some of the ways that we can work together by describing offers and asks. So centrally, in summary, we have a lot to offer in terms of experience, the coordination of activities, the pooling of resources, and shared learning. Our ask from you, I'm going to pull a couple of them out. The first one is that you engage with the prioritisation process, sharing what it is your thinking is about what you're going to do locally and what you need to do locally in this discipline. The second is that you nominate an expert user to be trained up to use the InHealth platform and to release time for them to be able to do that. We've got an opportunity in the next couple of weeks for people to get in on self-directed learning as a first stage, and then to be able to get training. And we need to have this cohort of people who are expert users so that we can move forward really quickly. So with that, I'll hand you back to Morag, who will take us through the next steps.
We have taken that stepped approach, and for a first go at this, it is open to suggestions, but we've tried to put it into a process. But as you can see, it's a very fast moving, and we do intend to take that agile approach to this. This is not something that is something that we expect people to go off and do on their own. As Scott said, this is a collaboration, and we will work with people. We will link up people together. Indeed, yesterday on the call, the boards were already beginning to link in with each other where they felt that they could offer their expertise or accept expertise from elsewhere. So we're going to use Teams. We're going to try that. We've got a Teams channel set up, and we will be leaving that as our area where we can collaborate, where we can put documents, and where we're experimenting with a Teams forum that we can actually get your input into as well, and make that as slick as we possibly can without lots and lots of emails and attachments where possible. By the beginning of next week, we're hoping to have the first nominations in for expert users, hopefully one from interested board areas. We will be looking for that so we can start to get them really tuned up on the actual platform itself, so they understand what the limitations, if there are any, but what are the opportunities and what can be done and what can be done easily. Let's keep this simple to start with until we get really comfortable with that one. The platform demo, that will be arranged for next week, and that will be an open forum for you to actually see with the suppliers, answer some of the technical questions, as well as actually seeing what it actually looks like in practice. We've seen bits of it, and I think that will be really interesting for people. But again, linking in with your expert users, the platform demonstration will then inform your opportunities list, and that's where we'll be asking you to submit a form telling us what your priorities are and where you think this could be an opportunity for your board area, particularly linking in with your national priorities as well. And then from then on, we will be having, as Margaret says, some individual calls with the local board areas to discuss in better detail what their requirements are, what their issues are, and what they feel we can best support them with from the central pot, as it were. And then from then on, as Scott has already said, we're not going to have formal business meetings, but what we will have is a weekly action group where people can come along and either introduce their solutions or their issues, working like a network to actually get that information exchange really active and agile, as I already said there. So hopefully that's sort of giving you a quick step, but you will see that's all right up to the kind of end of June. This is not a long term. It's going to take us months to even think about this. We really want to do this as quickly as we possibly can, and that's why we need to stand up some things that can be the quick wins, as Scott's already said there.
Okay, yeah, no, thanks a lot, Morag and Scott. I know there's been a number of questions and comments that are coming on the chat, so we might pick some of those up, and then, as I say, people can put up their hand as well. I know Laura Ryan has had to leave the meeting. She had asked a couple of questions, think more about the definition of people. I think when we've said normally well, we were meaning people who didn't have pre-existing conditions but developed COVID and required some monitoring in the context of the COVID symptoms rather than COVID symptoms, rather than other symptoms, I think is probably what was meant by that. The relationship to the national procurement, Scott, do you want to just pick up on that one?
Yes, certainly. So the national procurement is still running. This has been an emergency procurement. So we have access to this particular platform for 12 months. There's some scope to extend that, but not by very much. The national procurement just goes ahead. We anticipate having a concluded procedure early next year.
Yeah, so hopefully that answers that question. There's been one or two comments really about tech capacity, which Morag, I know we've talked about the support from a national level, some of the support locally, but obviously where boards don't have a lot of dedicated capacity. Do you want to comment on that one?
So that's where we're thinking we'll be able to link up some board areas and provide some support centrally to help them get started if that's the case. We see this as an opportunity, particularly for boards where they've not been the larger board areas, taking opportunities with the Home Mobile programme in the past. So this is an opportunity for them to perhaps get started. So we will provide what we can. And pull in some support for them where that's possible at all. So it's not a sort of, you have to be all up and running or anything like that.
Okay. There's also a question here, Scott, on what boards can do around developing forms themselves or needing in healthcare to do it for us. I mean, do you want to pick that one up?
Certainly, yes. The platform is designed so that you can develop your own services, so you can develop your own forms on the platform. However, you need to have an expert user who's trained up to use it, because it's not just a case of going in and writing your forms. The toolkit that I mentioned is based on XML, and it's got a visual editor that displays what you're building. There's a catalogue of instructions, I guess, that are written in XML that you can pick and choose, and you set them out in order. So yes, you can build your own from scratch, or you can pick up some work that others have done and adapt it for your own purposes. That was one of the big things about the InHealth platform that was appealing to us, because it's very similar in that respect to Florence. It's a bit more complicated to use in terms of you're getting to see the coding as you go along. But other than that, it gives us that huge flexibility. So yeah, build your own, fill your boots.
I think to add to sorry, Margaret, it was just to say to add to that, this is not something that we're just going to give you the license and let you loose with it. This is something we really want to try and coordinate centrally, so that we can actually make sure people are in the right position and the right place to take this forward, but then to share it. We really don't have time to sort of just let everybody loose themselves, and this is why we're looking for the expert users. And I see somebody has asked the question around what makes an expert user, and that's certainly a question we had yesterday. This is not necessarily needs to be somebody from an e-health background, as Margaret says, and Scott has said. It is based in XML, but it is a similar process to what a lot of the areas have already used for Florence or some of the other digital solutions. It's not an IT system that needs an IT person necessarily. It needs somebody with a background in process and can adapt and can actually work with the local teams, the clinical teams, to make sure what the end product is going to be suitable for their clinical needs and most important, the patient. So it's not just as simple as that. So someone with, as I say, if you've got someone that's already used Florence or one of the other similar systems and has a background in that one, then that's absolutely perfect. I think someone, but we can train them. I think someone that's not just is IT literate, and is not frightened of these. I think, and with an interest is more important than actual any qualifications as such.
Okay, I think Cliff has got his hand up. Do you want to ask a question, Cliff? I know you've posted a question on the chat as well.
Thank you very much. Am I allowed 2 questions? The first question was, I'm just wondering how this plugs into the National Digital Platform, because I know they've been working on citizen authentication as part of the eRespect form. So, I'm thinking ideally for NHS Scotland, maybe better still, NHS UK, we want to have one app that citizens have, which allows them to interact with the NHS in any way they want. So that was my first question: is how are we going to sort of corral all the apps together, or is this the one app that will do them all for NHS Scotland? And my second question is, if we've only got this for 12 months, what is the exit strategy from it? Because the data that goes into this, it's all part of the patient's record, so it'll have to be held somewhere, and it'll have to be available.
Yeah. Okay. So on the first question, we've been looking at this more from an integrations perspective rather than any specific use case. So the platform is open for a wide range of different integrations. If there's a use case that takes us into the National Digital Platform, great. We're happy to work with that. For patient authentication, that isn't a use case that we've seen yet in relation to this type of work. If it emerges as part of the work, then yes, again, we'll take that on, and we'll see how best to be able to achieve that. The second question is that there is exit planning provision in the contract that we have. That means that any of the work that we develop around developing service pathways is exportable, and we get to keep that, so that if we want to reuse it in with a supplier that we then use at a later date, we're free to do so because we've got the IP in it, and we have at least XML versions of the services. In terms of the data, then the data will be retained by the supplier until such time as we can give them a safe haven in which to deposit it, and we can manage the data thereafter.
Okay, just looking to see the issue about demonstration. Yeah, we did get a chance as part of the assessment of the various products to get a demonstration, but I do understand that that's going to be really helpful. I mean, Scott, is there thoughts about how we could do some sort of webinar demonstrations possibly that could involve in healthcare? And
yeah,
that's already in hand, Margaret.
That's in hand. Okay.
Scheduled for next week, and I agree. I mean, it's this is really just us trying to start the conversation, trying to get information out quickly. As Morag has said, we need to be very coordinated in our approach with this, and I think that being able to have that demo where we can invite as many people as possible to come and see will help them understand better how the platform can be of use to their particular situation. But that will be recorded as well, so even if people can't make it on the day, then we will make sure that the recording is available and accessible so that people can at least get that insight into the platform.
Margaret, there's a question there from David Rigby in Western Islands asking about what it adds over the other apps in Florence, and I think that's where I think Scott had already said it offers quite a bit more flexibility and integrated possibilities there. I think one of the things that we maybe didn't say so much is that it does have a care home option on it as well, which will allow multiple patients in a care home to be added to the system. So that's something that Florence can't do, or can't do easily. So there was a lot of things that we picked up when we were doing the national procurement exercise over the last year and more, that we recognised were key requirements of that platform to make it sustainable and fit for the future. And so I think there's a good many aspects of this platform that it wins over other offerings.
Yeah, there was a question also about shielding patients. So I think that's an important one. Yep. Vulnerable groups. We're collaborating as well with the National Connecting Scotland programme, which you may be aware of, which is really looking at people who are not digitally connected, either through not having a hardware device or having access to data or Wi-Fi. And there are, I think, up to 5,000 devices or 9,000 devices in the first instance being distributed via local authorities, working with SCVO in terms of how people are being assessed and what support they're going to get provided. So we're keen to link in with our tech work in terms of how we collaborate with that. I appreciate there'll also be shielded patients who don't that have digital devices, but I think that probably underpins the relevance of remote monitoring as part of that recovery plan, for people who hitherto may have been going out to appointments and hospitals, etc., but obviously trying to manage people safely at home, as close to the homes as possible. So we are working on that wider issue of people who don't currently have access to digital, that may well be beneficiaries of some aspects of remote monitoring.
I think there was another question about patients with a diagnosis of cancer as well, and shielding for surgery. It's more about what monitoring does that person require, and is it going to enable them not to have to come and put themselves at risk of infection at clinics and so on. So that will be over to your local areas to say, here's an area where we feel that some remote monitoring could help. So for example, we've already been working with the technology supporting maternity care, and we're testing it out using Florence at the moment, but that's another area where we could possibly quite quickly put a remote monitoring for their blood pressure and urinalysis onto this in health, which might give a better flexibility of device use for those particular mothers, pregnant women. So things like that, I think, is finding the best fit solution for your problem, rather than saying, oh, can we just use it for this, and oh, we could use it for that. It's identifying what your issues and what your priorities are. Hope that helps and covers that one.
Yeah, there's some useful suggestions coming there. Was there somebody else with their hand up, or maybe it's come back down again?
Sam Patel was unfortunate. I know he's in call today, so he's had to leave the call, but he had spoken to me earlier. And yes, it will be health and social care partnerships as well as boards, but we really want this to be a fairly coordinated approach from the board or health and social care partnerships as well. We don't envisage us coming from individual services saying, oh, could we use it for this, other than as at a national level, obviously, if that was a solution there. Yeah, there's lots. I think there's nothing off the table in this. This is where we're asking you for people for their opportunities and where they see the requests are, where their gaps are. It's not, but it is making sure that it is a relatively short term in the first instance, but it is going to perhaps help you get something started. Margaret, Jackie, Stephen.
Sorry, Jackie. Yeah, sorry, you've got your hand up.
Just because I had asked the question in the chat, but you've obviously managed to skip past it. So I'm just interested, Margaret, in how we're going to prioritise the proposals
Oh, sorry, yeah, that was one. Yeah.
Yeah,
Yep.
so just, because I absolutely welcome that there'll be a coordinated approach and we're all going to share the learning, and I have the advantage of some other people and having seen it, and it does look really good. But I guess, different boards will have different priorities and they'll be, champing at the bit, and I get they wouldn't all go off and do different things, but how will we collectively agree what the priority is, whether that's care homes or shielding patients or a respiratory pathway or a cancer pathway? Are you working on some criteria that will help to do that prioritisation?
Jackie, there's a couple of things in play. The first is,
Right.
actually, we don't know what the common asks are yet.
Okay.
So we could guess at the first 2 or 3, but actually there's probably more than that are, if not every board, then a good proportion of boards will want. So that'll be the first thing. And actually, if there's more than enough work to do in that, that's where we're going to start.
Okay.
Then we'll look at, okay, what are the other criteria, and we'll take expert advice from that on that. And that's when we'll really rely on colleagues in the Modernising Patient Pathway Programme and in primary care and social care to help us to be able to work out what the priorities ought to be. Now, there's going to be a balance here somewhere. We don't know where that is because we don't have the information to even start having the conversation. Does that make sense, Jackie?
No, that does make sense, yeah. And I guess so my other question would be around, once you've got priorities, are you looking for, so we had that governance diagram, didn't we? And I can't remember, were there 6 work streams? Do you envisage that we'd be able to move forward in parallel with something, the top priority for each work stream? Or, and I know we don't know yet, but I'm just trying to get a sense of.
We don't know yet, Jackie, but we do envisage more than one work stream or one thing going at a time, if we can possibly manage it, but it really depends on the ask, and that's where we'll have the conversations with individual boards. And I also picked up your question about versus local solutions. What we're not suggesting is that people ditch anything they've got and is working well just to jump on this platform. If it's already there and it's already working well and you've got something locally, then you think carefully about changing something just for the sake of changing it, unless there's good reason to be thinking, well, this is going to provide a solution to a gap or something that's caused barriers.
Yeah. No, that's really helpful. Thank you.
And Jackie, your thinking's absolutely right. Being able to move forward on many fronts is really what we feel that we need to do, and we can only achieve that if we get sufficient people trained up in the system and to get agreement around what the priorities are. I'd rather move forward with 6 things at once, knowing that we've got team A, B, C, D, and E looking after that with everybody's interests at heart, and then we can, if we can get the priorities and work through them quickly over the next 4 to 6 weeks, it means that we can then relax some of the central control so that you can do more of the local stuff. Okay. And for me, I know there's a tension there, but if we can do the greatest good for the greatest amount of people first, then we'd be delighted for people to do lots of local things.
Yeah, and I'm sorry I keep coming in, I'm supportive of that. I think so. The expert users, do you envisage that they would become part of a kind of national pool?
Initially.
Yeah, right, okay.
But they would be released back to local duties as early as we can.
Okay.
Well, also, Jackie, we've got the experience in this when we did the National Guidance Pack and the previous work we've done in the remote monitoring network, where we absolutely support each other. So there is a virtual support network there, and we would envisage that happening again. And to answer Shona Burge's question there about one expert user, we'll see what the numbers are looking like. We would perhaps do this in phases, where we would get the first phase and then, offer it to others, because we don't want that sort of single person and if they go off or leave or anything like that, then we need to pull that exercise. But we can do that as a rolling programme as well. Yeah. We need to get the first people through that have got a decent background in what we're trying to do, is probably the easiest way to do it. And then from that, it'll be a complete learning curve going on here.
Yeah, no, I agree. It's a multi-phase approach, and get the first cohort through, and they can help train the second and the third and the fourth.
Yeah, there's a suite of training information and videos and things there. That is an online training pack that we can obviously make available as well to support that. We'll do our best to make sure that's done.
I think there's
Alistair Graham.
Yeah, thanks, Scott. I'm just wondering, as you're speaking there, not just the expert users for the creation on the tool, but would you look to deliver some interfaces from the central group initially if they're part of indeed the pathway and the requirements?
Do you have something specific in mind?
I just could imagine there would be a requirement to send an output back to primary care, for example, no matter where there was a collection of data. To pick up some of the obvious integrations is there a way?
Yeah, okay, short answer on that one is yes. We know that there's a need to replicate what's been going on with Florence and the ability to send reports back into local systems. So yes, absolutely, and I think we already have some work in hand that's identifying the routes to integration. I think is probably the best way of describing it, and this early work will help inform specific asks around integrations, and that way we'll be able to progress that work hopefully quite quickly.
And I just had a supplementary, Scott, just in relation to the national procurement that was ongoing. You may not be able to answer this, but did all the providers that are active in that procurement put in an emergency bid for this procurement?
Now, I would love to be able to answer that question. I'm just uncertain of what I can and can't say because I'm in a live procurement.
That's fine. Just leave it, Scott. You can leave it. That's fine.
We have, well, what I can tell you is the stage in the national procurement that we are at is ESPD, which used to be called pre-qualification. So stage one is that we go to the market and say, this is what we're planning to do. Come and tell us if you would like to be considered for as a bidder. And we actually had 21 submissions or ESPD submissions as they're known, which is apparently quite a lot. So we're currently working through those. So you can imagine there's quite a scope of and a range of suppliers involved in that process, and we're currently narrowing them down to a shortlist, which, Alistair, is why I can't really say
to
your question. Does that make sense?
Yes, thank you for attempting that. Thanks.
Okay, thank you.
I see there's a question again from Jackie around the expert user, and I think my answer to that would be any expert user that we are training up, so certainly in the first phase, we would be expecting them to have the capacity to not only to be trained, and the only way they're going to learn is actually by being part of a wider group. So they will have to have the time to have the training. It's not an hour and off you go. There is some online training, there is some work they need to be doing on their own, but certainly we'd expect them all to be part of a network so that they can share the learning and learn from each other as well. I hope that's all right.
Can I supplement that answer with the training will be on the national we'll be using the national priorities to help learn, so they'll be learning and doing at the same time. It'll be supervised, it will be safe, but the best way to learn is to do the job when it comes to this sort of stuff.
Thanks, Scott. Yeah.
And don't apologise for asking so many questions. We're grateful for them, and the more questions that we get over the coming weeks, the better.
Yeah, it's interesting having sort of reviewed or had a look at the mobilisation plans from boards around digital and some of the teams coming out. Obviously, Near Me gets well mentioned, I think, in probably all the plans. I mean, remote monitoring much less so, but I guess there is some general intentions within plans around use of digital, and I know remote monitoring doesn't have the same. Near Me has got a very clear sort of description and understanding, and I think there was a huge amount of work done, obviously, to get all boards engaged in that. So again, I would encourage you, as part of the work on the mobilisation plans, to look to see how areas such as remote monitoring can support the work, and clearly what we've outlined to you is going in that direction. The capacity to have the COVID tool, I think, is still relevant. I mean, it's great that the numbers are going down. There's still numbers, but I guess there is ongoing concerns as the lockdown restrictions ease up a bit, that we will have potentially ongoing cases. We're not sure what the winter is going to bring, and I guess some of what we're doing around the COVID symptom management and monitoring could apply to, I guess, to a bad flu as well, in terms of how that's managed. So I think we feel there's quite a lot of application. But yeah, I would encourage you to work with colleagues in your own areas around the opportunity and prioritization of this approach.
Are there any other questions? Have we missed anybody's question? Put your hand up now. I've got a couple of minutes just left.
Sorry.
Yeah.
I think so. The thing about expert users and needing that for the 11th is quite a tight timescale if we're going to have to give them up to something national before we've worked out locally what we want to do. And I do see loads of opportunities for this. As I say, I've got the advantage of having seen it. So I'm just flagging it. For example, I might put forward somebody, but I don't know what their capacity is, because they're probably working on near me or something at the moment.
We absolutely recognise that, Jackie, and that's why we will do it in a phased approach. So we'll get the first people in, and we'll learn from that as well and get them through. But it is just we need to start and not take too long to sort of start getting going in the local board areas. So absolutely recognise that, but there's no point. We need to start training them now, because they will also inform what you might want to do locally as well. So there's a sort of two-way.
Thank you.
But so just to say thank you very, very much to everyone here. We are available. We are doing Teams, and as I say, we are available if you want to get in touch with the tech programme or Scott or myself individually. That's absolutely fine. I didn't introduce Joe McKee is project manager on the tech programme with us, and Tom Daly, who's the project support from the tech programme as well, working with us very closely. So just so you know, they're there, and thank you very much to them, because they do all the background work and keep us right. So thanks very much for your time, folks, and we hope to hear from you very soon. And don't forget to tweet and get this all going now. So thanks very much, Margaret. Anything else you want to add?
No, I think that probably sums up. No, thanks, Morag.
And Scott.
No, thank you very much, everyone, and let's keep the conversation going.
Thanks very much, folks. Bye now.
Bye.